We got it? Okay. Bismillah ar-Rahman ar-Rahim. It was a great pleasure, ladies and gentlemen, that I am presenting to you today. We're going to switch gears completely from fluids, hemodynamic changes, but into something that is very important, especially where the first speaker alluded to having source control and sepsis treatment would start from antimicrobials, and antimicrobial timing is extremely essential. Now, there is no guarantee that all what we face are only bacterial infection, and with the modern era, we're seeing more and more of fungal and invasive fungal infections in ICU. So this talk is going to be about that. Really quick overview to this is that we're going to go over regional epidemiology of fungal infections and risk stratifications and risk factors and specific fungal disease-related entities, and we'll touch upon specific therapeutic options, including guidelines and maybe if there is any space for aspergillosis in ICU. It may make some sense to talk about the distribution of fungal infections, and when I say so in ICU, I'm talking about Candida species and worldwide. It makes some sense. This is an Artemis study which looked into the different types of Candida species that were recovered over a period of 10 years. As you could see, almost 250,000 isolates, and they were from 41 countries, from 140 sites. And if you look, the Candida albicans in the first line were the most dominant type of Candida species that has been recovered and isolated worldwide, in the percentage of 60, I would say, to 75, depending on the time period. When I said it has some sense to know what's happening in the world, it makes far more or greater sense to know what is happening in the region. This is the particular data which comes from the Africa and Middle East from the same Artemis study, which showed that the Candida albicans is 67%. Now, what is more important is what we're facing in the same hometown. This is some data that I have gathered for this particular presentation to represent what an invasive fungal infection like to be in Kuwait. There are not a lot, but those little studies that are available that represent Kuwait will hold more importance to practitioners in ICUs in Kuwait than anywhere else. It indicated that, this is an old study published in 2000, that the Candida albicans were forming almost 50%, and the other Candida species forms the other 50%. This is a more recent and even bigger study for a good number of isolates, almost 600, by Professor Iman Muqaddas from Kuwait over 2 periods of times. And then you could see, importantly, that within the period of 2001 to 2005, the higher the number of more fungal isolates or Candida species were recovered in their hospital, indicating that people are more vigilant, knowing what Candida infection is, and then even the type of patients would render immunocompromised states to bring up more Candida. And then here it is where you see Candida albicans were making 40%, and a lot of parapsilosis relatively, which makes up to 30%. These are the susceptibility testing for those, and you could see that the Candida albicans in that large group is fairly susceptible to fluconazole. Here's another study with epidemiology of Candida colonization in intensive care unit in teaching hospital in Kuwait, where you could see that different varieties of Candida that could be known everywhere is present in Kuwait too. And this is another from a neonatal unit. Have you come across this alert which had come from the CDC and the WHO earlier 2 months ago about Candida auris, one of those new Candida species that is coming in an outbreak fashion that is thought to and is seen to be and featuring resistance to all types of antifungals. And if that threat is there, while I was searching for this, guess what? That's what I found. That in Kuwait in 2014, one microbiologist with the team of help with the clinicians, they discovered the first Candida auris in Kuwait 2 years before it was an issue by the WHO. So to say that we are not out of the woods, we are in Kuwait or we are in the Gulf states, that we just exemplify and we have what the others are having. Here is a pertinent study which comes from next door, which is from Saudi Arabia, from Riyadh. Simply 650 episodes of candidemia. And again, if you look at the right-hand side, you see that Candida albicans brings about almost 40%, and the others are non-albicans. And I will tell you why it's important to know whether albicans and non-albicans as part of that. This is their mortality, and then I will take you to do this. Now, what brings about Candida are certain risk factors, and these risk factors are many. There are the immunocompromised, which we know, and this is not the scope of this lecture because that is not our interest. Our interest as intensivists is what bring about candidal infection among ICU patients, and these are these particular risk factors. Every patient you have seen yesterday, if you were on duty, or even today, if you took around before coming here, you would have at least 5 or 6 of these risk factors. Now, would that mean, and I'm going to throw my antifungals on every patient that I am seeing having those risk factors? And mind that these risk factors, they compound and complicate, so having one bring about more. Here are some prediction models, i.e. there are some people who sat down and said, okay, there are risk factors, but maybe we should design and see what is the weight of these risk factors to predispose to candidal infection. And that what we call risk stratification. Here is one model by Ostrowski Zenker, who put patients who are having, or when the first 1 to 3 days being in the ICU using mechanical ventilation, on central line, having a central line and a broad spectrum antibiotic, and on any one of those would likely to predict them having a fungal infection. But important to see is that your sensitivity is only 70%, and the important side is the right side of the slide, which said positive predictive value is extremely low, and negative predictive value is extremely high, is more than 98%. Now, what does that mean? It means if a patient in the ICU fits that, he is possibly having a fungal infection. It doesn't tell you how much that possibility is. But if he does not fit this criteria, it gives you a lot of confidence to say he does not have a fungal infection, and I'm not going to start an antifungal for him. So same thing was with another rule by D. Point, which suggests that predicts the yeast isolation in peritoneal fluid in ICU patients with peritonitis. They happen to have 4 factors, female genders, and sorry for the ladies, but that's what the study showed: upper GI tract of peritonitis, intraoperative cardiovascular failure, and previous antibiotic. Same exact thing. The positive predictive value was very low compared to high negative predictive value. So it gives exactly the same prediction like I have alluded to in the first one. The third, which is a well-known Candida score, is our commonest, that is used very frequently because it's fairly easy to remember, and it's very popular for people to show in the ICU, and as stated. Same exact thing for negative and positive predictive values. So in all, so having those models helps possibly to know more who is not having a fungal infection than those whom we should start. So until we know more, the data has to be dealt still with on case-to-case basis. Touch upon central lines. This is a study which have shown an evidence that central line, if it's the cause for the primary candidemia, needs to be removed as soon as possible. And what they have found here is in the red rectangle, which I am trying to refer to you, is that when you were to, above the rectangle, you see adequate antifungal treatment, there was no difference even if you were to start it very early. But when you remove the central venous catheter within the first 24 hours, there is a difference between survival and death. And then when you obviously combine antifungal together with the central line remover, you have the best survival rate. And now we talk about risk factors for resistant Candida, and that's the reason why I discussed the epidemiology of Kuwait, showing that you only have in Kuwait in the range of 40 to 50 Candida albicans, and non-albicans are the other 50%, which means having critically ill patients or people who are in hospital environment or azole prophylaxis or prior treatment of azoles may bring about other Candida species which you may face and may bring either resistance or failure to fluconazole if that's the only agent that you have. And whichever is fluconazole susceptible, likely to retain susceptibility to voriconazole, but you cannot take it for granted that if it's something or Candida isolate that is resistant to fluconazole will retain susceptibility to voriconazole. Like you see, only 50% of those are susceptible. Unlike the rest of the world of the antibiotics, if you were to give antibiotics, you give Piptazo to Pseudomonas, you will lose it in a week. You give quinolone, you will lose both Piptazo and quinolone, and so on and so forth. So if you were even to give caspofungin, likewise, you're likely to change the distribution of Candida species, and you may get the resistant ones. Okay, here are 2 common entities of Candidal infections, or Candida recovery, I should say, or isolation in the ICU. What happens, and I'm sure for the group of intensivists who are here, you're definitely faced with this. You recover yeast in the respiratory sample, whether being sputum, deep tracheal aspirate, or even a lavage in a careful bronchoscopy, or when you recover it in urine. Do we have what we call Candida in the pneumonia, or Candida pneumonia? Here is a study to prove or disapprove that. This is an autopsy study which looked into almost 1,500 admissions in one ICU, of which 300 died. And those among those who died, 230 of which gave autopsies. Now, you would love to get lung tissue from alive patients, but that's very, very difficult to get to design a study for. So for 230 autopsies they were taken, they looked back into their records when they were alive. And then they were looking whether they were having pneumonia when they were alive or not. 97 did not. They were taken out. 135 had evidence of pneumonia, and they took them. Among those, there were 58 patients who had respiratory sample negative for Candida, and 77 who had respiratory sample positive for Candida. And then they wanted to see whether they had Candida pneumonia or not. They have defined Candida pneumonia by the exact gold standard histopath definition, whereby they were looking for invasion of Candida within the tissue. And that's what they found. 0 among those who had Candida in the respiratory sample, and 0 Candida pneumonia among those who did not have it. So that really takes away whatever we think of as a source of, as Candida as a cause of a pneumonia, especially among critically ill patients. And candidiuria is the second entity whereby you have asymptomatic candidiuria. Treatment is not recommended unless it fits one of those. And most of the time, our patients that we have in the ICU do not fit that. So most of the time, you would not require to treat. And those whom you need to treat are those with symptomatic candidiuria with cystitis pyelonephritis. But you need to define it, if it is the case or not. And here are the other options to do so. Now, we come to the therapeutic plan. We either deal with Candida infections in the form of prophylaxis, preemptive, empirical, or therapy. We would love to be more than empiric, being ahead of time, treating as preemptive. Unfortunately, that is difficult because the markers that we rely on are not present in most of the hospitals. And we would wish that at least we would do it the empirical as soon as possible, because data have shown that the mortality is higher, like that of antibiotics. Same thing for antifungals. When you delay it, you're likely to increase mortality. The guidelines from many parts of the world, being the American guidelines, the European guidelines, or even a group of us in the Middle East sat and wrote down, and even for the German-speaking guidelines, will be, I have summarized to you to be channeled in the following few slides to simplify it. I've taken the IDSA, which is the Infectious Disease Society of America guidelines, as an example, but they are basically the same thing. If you look carefully and read all the guidelines, they end up being the same. For the non-neutropenic patients, which are the ICU patients that we're all dealing with, the primary treatment for those empirically would be echinocandins with the different variety of drugs that you see. Your alternative would be fluconazole and lipid-formulated amphotericin B. If you have to have a proven candidemia, then same thing. You would go primary treatment with echinocandin, and then you may de-escalate at a later stage to fluconazole. Or if there are alternatives that you cannot give echinocandin, it's not present, you have drug-drug interaction with fluconazole, something like that, lipid-formulated ampho-B, and maybe voriconazole is an option. Among the neutropenic patients and neutropenic adults, although they may not be our business every day in the ICU, but if they happen to be, then echinocandins and the rest follows. So the empiric antifungal treatment is what you have will rely on the following. It will rely on risk stratification, Candida species, local data, resisted Candida isolates, site of an infection, presence of the catheter. You have to put all of this together, and the hemodynamic and stability to put that all in perspective. One last word about, is Aspergillus among critically ill patients an issue? Now, we know that we recover Candida most of the time in the ICU. Are we recovering more Aspergillus? You would be seeing every now and then that you get Aspergillus, not among immunocompromised or status post-bone marrow transplant or chemotherapy, but we still have them. Recent data have shown that, yes, there are some risk factors which bring that about to the ICU patients, and you probably need to be more vigilant and looking carefully into those types of patients, and you have to seek advised by infectious disease services or microbiology to help you decide the treatment. I think I made that slide to be my last, and I thank you so much for your attention. Thank you.